FREDRICK on glaucoma associated with trauma, and Dr. Rupesh will be joining us.
Rupesh will be joining soon.
Thank you, President Grover, sir, and all the team leaders of OTSI. It's indeed an honor to be part of this national symposium on ocular trauma. And my talk is on management of glaucoma following trauma. As you all know, traumatic eye injury is one of the most common cause of unilateral blindness and avoidable blindness worldwide. And traumatic glaucoma can happen with both open globe injury as well as closed globe injury. And it can happen immediately as well as delayed. So as for the definition, this really helps in management. You need to have any post-trauma with raised intraocular pressure more than 21 millimeters, which may be acute or chronic, blunt or penetrating, with or without establishment of glaucomatous optic neuropathy. Now, these are some of the risk factors for developing glaucoma: advancing age, the zone 2 injury, presence of vitreous hemorrhage, severe anterior chamber inflammation, and lens injury and angle recession. And the management depends on the risk factors also. So glaucoma in blunt versus penetrating ocular trauma, it can happen, as I said earlier, both in closed glaucoma, closed globe, as well as open globe because of these reasons. I'll just go one by one. The causes of traumatic glaucoma is basically direct or indirect. And with direct, it's on non-penetrating as well as penetrating. And of course, surgical trauma also can cause raised intraocular pressure. So how to approach this? So first, you need to evaluate the patient health and ability to follow a post-operative regimen, because this regimen is going to be long and needs frequent follow-up. Consider the time that has passed since onset of injury. And most often, if it's acute phase, medical management is mandatory to start with, and then decide the etiology of elevated intraocular pressure, perform a proper evaluation, and if the cornea is clear, gonioscopy, or we can use other technological method for imaging. Assess the status of the ocular surface and the presence of other ocular conditions, and determine the patient visual potential and weigh the risk-benefit ratio of potential complications. So in the acute phase, most often it's due to hyphema, traumatic iridocyclitis, or shallowing of the anterior chamber due to effusion, and vitreous in the deep vitreous dispersion presence in the deep anterior chamber. So in the acute phase, of course, medical management is necessary to start with. So you can have topical beta blockers like temolol or the combination medicines, and then the carbonic anhydrase inhibitors, again a combination medicines. And if it is not settling with medical management and the hyphema is more than 7 days and intraocular pressure more than 35 days, or in grade 3 hyphema, so we resort to surgical evacuation. And this is to reduce the intraocular pressure, as well as if it is more than 8 days, to reduce corneal blood staining. And if there is associated iritis or cyclitis, we can use antifibrinolytic agents in the presence of hyphema. And you have to use systemic and topical steroids because topical steroid reduces the inflammation, and sometimes systemic steroids also need to be adjunct solution. Cycloplegics are mandatory in the presence of iritis and hyphema, and we can consider giving the rest. These are all olden methods, but still valuable, particularly in young patients. Elevating the head and monocular or bilateral patching is necessary. And late onset glaucoma, various manifestations, but the commonest one is angle recession. It can also produce in cases with peripheral anterior synechiae, Gosel glaucoma, retained intraocular foreign body, or in the later stages, epithelial ingrowth and cyclitic membrane. So there are two peak incidents with reference to angle recession glaucoma. The first peak within the first few weeks, and the second peak late onset. And the medical management for angle recession, the biotics are ineffective because the scar in the ciliary area, and beta blockers and carbonic anhydrase inhibitors can help to a certain extent. And the IOP raise can be controlled with medication alone in early cases, and in the late intraocular pressure raise, you have to resort to some surgical intervention. So in traumatic glaucoma, why surgery is better? Because it's reasonably effective and safe and widely accepted, because most of our patients are younger patients, have a long life expectancy. Maintaining them on lifelong medication is difficult, and tube shunt surgery, it can be an appropriate action. So particularly in younger patients, when the presentation is much younger age group and the disease is advanced stage, surgical intervention really helps, because most of these patients whom we see are lost for follow-up or have poor compliance. And early surgical intervention is mandatory in cases of hyphemia, as I said earlier, and higher baseline intraocular pressure. So what are the options in glaucoma surgery? Obviously, trabeculectomy is the standard of surgery. And if it is a long-standing trauma with scarring, definitely antimetabolites like mitomycin C will help. And as I said earlier, glaucoma drainage devices. In some of the cases, lens extraction can help, particularly intumescent post-traumatic cataract, or in some cases, goniosynoculitis and vitrectomy and retinal surgery in complicated cases. So when to operate is the benefit really worth the risk? So you have to take a risk versus benefit. And of course, the younger age group and aphakia or pseudophakia, the surgical management really is better. If there is active ocular inflammation, you have to control the ocular inflammation with steroids or anti-glaucoma medication. And in neovascular glaucoma, obviously, it's a difficult choice. So we have to resort to surgery later on. So basically, subscleral trabeculectomy, and because of the increased risk of blood failure, you have to consider mitomycin C or bifluorouracil in the postoperative period, and Ologen, and IOP and risk factors also has to be considered. So the fornix-based incision is the choice of incision, and you have to ensure that you have do a thorough dissection and also manage the Tenon's capsule in a better way. Enhancement of surgery with the use of intraoperative mitomycin C or postoperative bifluorouracil, topical and systemic steroids, and of course adjustable suture or laser suturolysis can help. In the postoperative period, you have to follow them frequently, look for blood failures, thin bleb, or the anterior chamber reaction, and also have to use topical steroids and antibiotics and NSAIDs in the long run with lubricants. Tube shunts are a good option in late onset cases or following a failure of mitomycin-based trabeculectomy. So what we need to do is assess, have a system for surgical management of traumatic glaucoma, treat the patient, not an abstract concept that is only the intraocular pressure. So see how we can preserve or enhance this person's health, and what other complications. For example, most of this patient might need a retinal surgery, might need a vitrectomy, and also the surface management. So you have to see all these factors and choose the better option for preserving this patient's vision as well as ocular health. Thank you so much for your kind attention.
Thank you for a
Thank you.
thank you for a very well organized talk and a very
very helpful
finish.
clinically.
A couple of questions.
Sir,
when do you say in a given situation, when would you choose a shunt versus a trabeculectomy with mitomycin C?
Exactly.
Are there any studies to guide us?
There are a lot of studies comparing the efficiency of subscleral trabeculectomy with mitomycin C and tube. But most often, tube shunts being the last resort. And our surgeons are happy with doing subscleral trabeculectomy because of the long duration of our exposure to trabeculectomy. I would prefer doing a subscleral trabeculectomy if at least
as the first procedure.
As the first procedure, of course, with adjuvants like mitomycin C or Ologen. But if there is a failure, then I would definitely consider the shunt surgery. So the first choice would be subscleral trabeculectomy.
Prashant, are you there?
Yes, yes.
I think the post-vitrectomy glaucoma is an extremely difficult situation. Would you like to say something regarding that?
Yeah.
Particularly in trauma.
Yeah.
I'll add another question to that. When you do a shunt or an MAD wall with that in a post-vitrectomized eye, do you prefer to leave it in anterior chamber or would you leave it posteriorly?
Sir, the thing is, my first choice would be if the trabecular meshwork is totally fired off. The traps are usually unlikely to help in such cases, and in that cases, AGV would be the point of procedure of choice for me.
Right.
But yes, now if it is a vitrectomized eye and all that thing, I might put it in the pars plana. But in a non-vitrectomized eye, I prefer to put it in anti-chamber as a primary procedure.